I just run with this. First of all, I want to say that I agree with Professor Ayman in many points he mentioned, but I'd like just to present from the other perspective. My talk is divided into two parts. First, for osteotomies, the theory, the concept, and the second is for some clinical scenarios. Starting with the first one, this is Professor Rolly Yaqub. I met him around 15 years earlier in Innsbruck for the conference of the ESCA, and he was presenting some amazing cases about cartilage defect management. He showed some cases of management of cartilage defects even on the undersurface of the patella for all patients. I asked him a very direct question after his presentation. I said, why not to do total knee arthroplasty in spite of this very long journey treating cartilage defects in those old people? He said, I'd like to do more sustainable solutions, and still remember his own words, literally. I asked him, my dear professor, what do you mean by sustainable solutions? He said, osteotomies and repairs. And he said it this way. And since then, my career has changed. Let's be very basic. What kind of pathology do we have here? We have some kind of cartilage wear and degeneration. Why is this happening? Because there is some kind of overloading over this cartilage. The original function of cartilage is to absorb loading, and this is over more than its capability to tolerate. That's why it is desiccating, degenerating, and getting worn. Otherwise, why do we do osteotomies concurrently with cartilage and meniscal repairs? To give the chance for these overloaded compartments, for these repaired structures to heal. So the story is that we have horrible stresses over the medial compartment for an extra load due to the deformity, due to varus. And if the patient is having some kind of overweight, the problem would be rather severe. And we stand on a very solid background biomechanically. We know that contact pressure very simply equals the very simple equation, force divided by the area, provided that we have some factors affecting the force, like the weight of the patient, and some other factors affecting the surface, like the sloping of the recipient surface, the structure of the force absorption cartilage. But in the end, it's simple. It's some more forces focusing on the medial compartment led to what we have of cartilage disease. So why we should save cartilage? First of all, I have a very personal reason. Why should I strive to save cartilage? I must say, ladies and gentlemen, I'm in love with cartilage. And if you went deep into the biology, histology, and biomechanics of the articular cartilage, you would be in love with this structure, as I'm doing. Do we have other causes? Yes, I believe that cartilage repair do exist, and I'm going to present in a few minutes a very important pieces of literature that supports this. So I'm going to forbid my patient from this repaired, between brackets, cartilage, if I kill this cartilage. I never kill articular cartilage unless it is deadly. At this time, I shoot it, the bullet of mercy, by effecting my saw, resecting this cartilage and putting total knee replacement as a final solution. Otherwise, I won't do that. And because the change of the biological environment of the knee, I believe, would not get any better results compared with leaving the cartilage in place and leaving the capsule without opening it. Is it only emotional, or is it supported by literature? There is a couple of papers published by Henning Madri. He is a basic scientist. And he, in the first one, gave an evidence that there is a site-specific effects of varus malalignment and supported the clinical concept of therapeutic unloading. And in the other one, which is more important to my mind, he gave an evidence that there is an osteochondral, some kind of osteochondral recovery upon unloading symptomatic isolated medial tibiofemoral knee osteoarthritis. So there is some kind of repair, some kind of breathing. The cartilage is going to have it once again, once you offload the extra loads. And I got some questions for you. First of all, who's the victim now based on this background, and who's the criminal? I'm not going to answer. This is open for you. What we exactly do with uni? It's surface replacement. Okay. By that, did we manage the original overloading pathology? Okay, what happens if overloading continued? The miraculous creation of Allah of God has failed to tolerate. Is metal and plastics made by the hand of mankind going to tolerate? Why is the reputation of the short living of the uni? Why is the higher conversion into total knee replacement? Isn't because we didn't manage the original overloading pathology? Some other questions. Is there any difference between interarticular and extra-articular procedures? Which procedure is more capable of regaining kinematics and range of motion if we open the capsule or left it intact and work it outside the knee totally? How is the ability to correct deformities? How about the femoral deformities? We cannot do anything with uni for this. How is the rule of ligament deficiency? If I have ligament laxity, I might defunction it by a little bit overcorrecting by doing osteotomy. Uni cannot do that. How about return to sports? How about failures and complications? If I have a failed osteotomy, I'll just remove the plate and convert into a total knee. Uni compartment is some kind of arthroplasty still. How about infection? If I had infection during osteotomy, I'll just merely remove the plate. But if unicompartmental having infection, this is the dilemma of the whole arthroplasty infection. How about the costs? And if you look at the literature, tens and tens of papers are in support of osteotomy and in support of unicompartmental. But I think the message is that we should look critically at the literature to extract our pieces of information. For example, this paper is in favor of more conversion of uni to total, and this is well known. But the author claimed that there is higher rates of reoperation for osteotomies. And when I went into the depth of this paper, I found that he's counting the removal of hardware as an operation of complication. This is unfair, of course. And by the end, he stated that osteotomy survivorship curve is greater than uni. Why didn't you mention this from the start in the title of your paper? On the other hand side, and to be fair, there are some other papers entailing very good results for osteotomy, even if it is in old age. And this is different in the Middle East and Egyptian society. I think we should take this very carefully, and age is, in my mind, an obstacle. To end this part of my presentation, this is the list of indications, and it can be stretched more and more. But the message is that the patient should be indicated, yes, but should be selected at the same time after being indicated. And the second part of my presentation is some clinical example. This is what you do as arthroplasty surgeon. Sometimes you do this. This is a 50-year-old lady who admitted to my office having evident varus, having medial compartment failure and complaining of pain on medial side of the knee. And I advised her, I recommended to do osteotomy. She went to the States and did that and came back to me. I'm still having pain on the medial compartment. I'm not feeling comfortable. And her surgeon is telling her that everything is all right. I looked at the x-ray, and to my mind, I'm not an arthroplasty surgeon, but I said, I think it's okay. She went back to him, and he did that. She's 50. She's not overweight. She doesn't have any comorbidities. She's very active. She's a housewife. And then she came back to me once again. I'm still feeling not happy. What can I do? I looked back again at the x-rays. I cannot find, to my mind, any pathology. But the stitching film may dictate the secret for this. Still in market varus. What we do is different. I'll show you 4 cases on a hurry for advancing degrees of arthritis. This is the first one, simple, medial compartment osteonecrosis, medial side of the knee. This is the stitching film, and this is what we do. Simply osteotomy, and this is on the right-hand side, the post-operative stitching film. Case number 2 with increasing degree of arthritis. This is rather more severe degree, and this is what we do here. This is the osteotomy, and this is the post-operative alignment. Going into depth more and more for severe cases, yes, I do them osteotomies. This patient, would anyone in this room recommend anything rather than doing total knee arthroplasty for him? I would do. This is the stitching film. Around 22 degrees of valgus deformity. I divided the procedure. This is his horrible MRI, and this is what I did. And this is the Schuss view. I understand that the joint line is oblique because he's still having another stage of distal medial closing wedge femoral osteotomy. And this is his alignment after the first procedure. He's happy. He's a manual worker. He's 41 years old of age, and he's now active. The last patient is that one. He is 39 years of age, having that degree of arthritis and anemia compartment of the knee for that degree of deformity. One moment, can I have it? Last. That's his stitching film, severe degree of varus deformity on the right as well on the left side. This is what I did him for the right side, double level osteotomy, which is very successful. He came back to me asking to do the left side. I did him the left side, and this is the final stitching film. And this is him walking after having both procedures. He's back to life, 39-year-old employee. So save the cartilage. He's the victim. He's not the criminal. And selection is far different from indication, something else. And we should be reading the literature carefully. In the end, I invite you to a London osteotomy course, which is going to be held for the first time in Cairo here on the 30th of November. A number of world-renowned osteotomy surgeons going to attend. Roland Varden from Amsterdam, Adrian Wilson from London, and Christian Clay from Hanover. I'd like to thank you for your attention, and if you're going to hate me, please be soft.